So there was some problem with the network connectivity again. I think that is the reason why, though I spent 15 minutes explaining about these two compounds, you are not able to access the live stream. Now again I am hopeful that we have gone live. So let us start with the miscellaneous category of the cytotoxic drugs. So in the morning, if you recollect, there was this anti-malignancy antibiotics which were also cytotoxic that I mentioned. Now what you have is the miscellaneous category. So this category doesn't have any specific big list of drugs which have a common mechanism of action. There are two drugs and each of them has a different mechanism of action, therefore we put it in the miscellaneous category. Now look at the first one, the hydroxyurea. It has got a unique action. Hydroxyurea is inhibitor of ribonucleotide reductase enzyme, and you know that ribonucleic acid is formed first and then the deoxyribonucleic acid is formed from it. So ribonucleic acid becomes deoxyribonucleic acid because of the action of ribonucleotide reductase enzyme. Hydroxyurea is an inhibitor of that ribonucleotide reductase enzyme. When you inhibit the ribonucleotide reductase, ribonucleotide cannot become deoxyribonucleotide. So the deoxyribonucleotide, if it is not available, the DNA replication cannot happen. If the DNA replication cannot happen, the cell will not be able to proliferate. And that is how the mechanism of action of hydroxyurea is as an anti-malignancy agent. It interferes with the replication of the DNA by inhibiting the formation of the deoxyribonucleotides by blocking the enzyme ribonucleotide reductase. Apart from being an anti-malignancy drug, hydroxyurea has got certain other therapeutic uses which are actually much more important and unique. For example, hydroxyurea is also used in the treatment of sickle cell anemia. Now its sickle cell anemia use or its mechanism of action are quite different from its cytotoxic action. Its cytotoxic action is by inhibiting the ribonucleotide reductase enzyme and by not allowing the deoxyribonucleotides to be formed and therefore interfering with the template function of the DNA, not allowing the DNA to replicate, and therefore the cell dies. Here in case of sickle cell anemia, what does hydroxyurea do? Hydroxyurea suppresses the production of beta globin chains. We all know that in sickle cell anemia there is a problem with the beta globin chain. In the sixth position of the beta globin chain, instead of glutamic acid there is valine, and that is how the abnormal structure of the beta globin chain leads to sickling of the RBC, especially when there is relative hypoxia. Now that sickling of the RBC is little tricky and dangerous because that sickling will lead to occlusion of the microcirculation, and that will lead to vasculitic crisis, and that is very clinically disabling to the person, and also in the long term the consequences will reduce the longevity of the individual. So the complications of sickling are quite acute, and also in the long term they will reduce the longevity of the individual. So therefore the sickling has to be reduced. And how do we reduce the sickling? We can't do anything to the beta globin chain, so hydroxyurea goes and inhibits the production of the beta globin chain, and more importantly increases the production of gamma globin chain. And you know, alpha 2 gamma 2 chains, when they form a polymer, they lead to the formation of fetal hemoglobin. So adults normally we don't have the fetal hemoglobin, but here when the beta globin chain is abnormal and it is increasing the risk of sickling and it is increasing the risk of vasculitic episodes, it is better to have a fetal hemoglobin than to have a abnormal adult hemoglobin. So hydroxyurea increases the production of fetal hemoglobin by increasing the gamma chain synthesis, and that is how it is used in the treatment of these sickle cell anemia patients. It is one of the important uses of hydroxyurea apart from its use in treatment of leukemias. So both lymphoblastic and myeloblastic leukemias, hydroxyurea can be used, but apart from that another important use is in sickle cell anemia. The other use is it can also be used in psoriasis for its immunosuppressive effect, because it is cytotoxic, because it is going to reduce the production of the leukocytes. The leukocyte count, when it comes down, the cell mediated immunity comes down. So psoriasis also it can be used for suppressing the autoimmune manifestations. And the other thing is it can be used in so psoriasis is one use. It can be used in polycythemia vera, where increased production of the RBC due to a stem cell defect leading to excessive production of the erythrocyte precursors, and there the bone marrow depression that is induced by hydroxyurea can be used. So it can be used in polycythemia vera, it can be used in psoriasis, and it is one of the important agents in treatment of sickle cell anemia apart from its use in malignancies. And type of malignancies where it is used primarily is leukemias, so myeloid as well as the lymphoid series leukemias it is used. What are the adverse effects? Most importantly, because it is interfering with the deoxyribonucleotide formation, because it is interfering with the DNA replication, it will lower the cell count everywhere, including the bone marrow, and therefore it will cause bone marrow depression. So one of the important adverse effects of this is bone marrow depression. Of course, not only the cells in the bone marrow are vulnerable, even the cells in other parts of the body where the rate of proliferation of the cells is high, they all suffer. So which are those sites? The gastrointestinal tract mucosal epithelium suffers, and that will lead to abdominal pain and diarrhea, and also the cell proliferation in the hair follicle will suffer, that will lead to alopecia. So most important is of course the bone marrow depression, which is clinically very serious, because severe bone marrow depression can lead to secondary infections and sometimes septicemia and death also. So hydroxyurea mechanism of action is ribonucleotide reductase inhibition. Ribonucleotide reductase inhibition deprives the cell of the deoxyribonucleotides that are required for DNA, and DNA cannot replicate, therefore the cell is not able to proliferate and it dies its natural death. Then hydroxyurea has a role in boosting the fetal hemoglobin, therefore it is used in sickle cell anemia. Because of its immunosuppressive effect, it can also be used in psoriasis, and of course because of its anti-proliferative effect, it can also be used in another condition called polycythemia vera, bone marrow depression being an important side effect of this compound. Then we go to the other drug, that is L-asparginase. Now this L-asparginase has certain unique features. This L-asparginase is obtained from E. coli, and as you know, because E. coli is the source of this, now whenever it is formed, it will have certain antigenicity associated with it, and people who take it might get allergy, hypersensitivity, and sometimes frank anaphylaxis also. But what is the background? Why do we even use asparginase? So asparginase, what is its function? Asparginase enzyme's function is to break aspargine to aspartic acid. So aspargine, which is an amino acid which is active, can be inactivated and broken into fragments of inactive particles called aspartic acid. And asparginase, whenever we administer, will turn whatever circulating or intracellular aspargine is there into inactive aspartic acid. Where do we use this? What is the rationale of using this? This actually, asparginase role has come up after several observations. Systematic experiments have shown that leukemic cells especially are deficient in aspargine synthetic enzymes. So aspargine synthase is the enzyme that is responsible for synthesizing aspargine, but the leukemic cells don't have this aspargine synthase enzyme. Because they don't have this aspargine synthase enzyme, they cannot synthesize aspargine. Therefore, they will need aspargine, but they cannot synthesize aspargine. When you need something and you can't synthesize, you have to grab from somewhere. And this leukemic cells, they grab this aspargine from circulation. And when they want to use this aspargine, if you expose them to asparginase, asparginase will break down that aspargine and will not allow the malignant cells to have access to aspargine. So that is how the malignant cells will be deprived of aspargine in the presence of asparginase, and they cannot synthesize their own aspargine, therefore the cells will die. And this is the mechanism of cytotoxic action of asparginase. And the good thing is, because the human cells which are non-malignant, they all have the ability to synthesize aspargine, they will not suffer any problem with asparginase. So the bone marrow depression, the gastrointestinal tract distress, the diarrhea, the alopecia, the gonadal dysfunction, all those adverse effects are not there with L-asparginase. So this is an enzyme, it is obtained from E. coli. It is specifically targeted towards the leukemic cells. In other malignancies, it doesn't have much role. It doesn't have any toxicity on most tissues of our body, because most cells in the tissues of our body don't need an external supply of aspargine. They can synthesize their own aspargine by using their enzyme aspargine synthase. So asparginase will not have much effect in the normal cells of our body, but it will definitely be having tremendous impact in exerting cytotoxicity and depriving the malignant cells of the much needed aspargine. So the malignant cells will suffer much more than the usual cells. So the usual adverse effects of bone marrow depression, the peripheral neuritis, the alopecia, the GI distress, the gonadal suppression are all not there with asparginase. So this is the unique feature of asparginase. All the classic adverse effects of cytotoxicity that are there with most anti-malignancy drugs are not there with one of the cytotoxic agents. Which is that cytotoxic agent? That is asparginase. So an enzyme which is an anti-malignancy drug is asparginase. A drug which is having cytotoxic action but doesn't have all the adverse effects of the regular cytotoxic agents is L-asparginase. And a drug which is used in anti-malignancy, which is obtained from microbiological source like E. coli, which may increase the risk of allergy, hypersensitivity and all, L-asparginase. So this is about hydroxyurea and asparginase. Now let us go to drugs which are targeted in their approach. See, all this while we were studying drugs which didn't have that much distinction between a normal cell and a cancer cell. But as we moved to asparginase, at least asparginase was having relatively more specific action on the malignant cells rather than the normal cells. So there was some type of advantage with this asparginase, but the problem is what happens is there is tremendous capability of these malignant cells to rapidly become resistant to asparginase. So most leukemic cells and other cells, they become rapidly resistant to the action of asparginase because then they will have an expression of the aspargine synthase enzyme. Normally the malignant cells, they think that why should we have aspargine synthase, and we targeted it by using L-asparginase because they were depending on external supply of aspargine. But what happens is over a period of time the malignant cells become intelligent and they start synthesizing their own aspargine. Then N-asparginase will not have much role. So that is one limitation. Asparginase may not be having a long-term success because malignant cells rapidly develop resistance to asparginase by developing their own synthetic mechanisms for aspargine. And some malignant cells are so intelligent that they will develop such type of mutation that they don't require aspargine for survival. So then whether you give asparginase or no asparginase, it won't hurt them because they won't need aspargine in the first place. So that is why asparginase in the long term may not be really very useful. But other drugs that we have seen, all of them, they have bone marrow depression as an effect, GI distress as an effect, diarrhea as an adverse effect, neuropathy as an adverse effect, gonadal suppression as an adverse effect because they are cytotoxic. Though they have preferential cytotoxicity towards the malignant cells, we do not have any cytotoxic drug which is free from the adverse effects on the bone marrow or the hair follicle or the skin or the mucous membranes or the gonads. They still have some effects on all of these sites. So we were searching for some compounds which have very, very low or no adverse effects on other tissues of the body and will have purely effect on the pathophysiological mechanisms in cancers. And our search led us to targeted drugs. And first category of them is tyrosine protein kinase inhibitors. From your knowledge of the initial classes in pharmacodynamics, you will recollect that there is a topic on receptors, and then there are certain types of enzymatic receptors, and some of the enzymatic receptors are tyrosine kinase receptors. Some of the proteins that are formed in some malignant cells which are responsible for ensuring the rapid proliferation of the cells. One of them is tyrosine kinase. So tyrosine kinase, if it is overexpressed, the tyrosine kinase can phosphorylate certain intracellular proteins, and those intracellular proteins then actually can accelerate the rate of proliferation of the cell by suppressing pro-apoptotic proteins and facilitating anti-apoptotic proteins. So that is how some malignancies actually initiate their massive survival. How do they initiate that? They replicate so rapidly. How do they survive so well? Why do they have very high proliferation rates? Because they activate certain protein kinases which are tyrosine protein kinases, and those protein kinases phosphorylate intracellular proteins, and those intracellular proteins then actually suppress the pro-apoptotic proteins and stimulate the anti-apoptotic proteins, and therefore the apoptosis is inhibited and there will be massive proliferation of the cells. Now, one of the examples of the tyrosine protein kinase role in case of a malignancy is seen in chronic myeloid leukemia. In chronic myeloid leukemia, there is a BCR-ABL gene. So breakpoint cluster region Abelson gene. So whenever there is a reciprocal translocation between the long arm of 22, long arm of 9, the gene that is being formed there abnormally is the BCR-ABL gene. And that BCR-ABL gene codes for a certain protein. And what type of protein is it? It is a tyrosine protein kinase. And because of this tyrosine protein kinase, there will be signal transduction that leads to activation of so many. Kinase means phosphorylation and activation. So many intracellular proteins will get activated, and what will they do? They will inhibit apoptosis. And when apoptosis is inhibited, there will be massive cell proliferation, and that is how chronic myeloid leukemia happens. So imatinib, nilotinib, if you see these two drugs, they are inhibitors of the tyrosine kinase. Which type of tyrosine kinase? Specifically that tyrosine kinase which is formed as a product of BCR-ABL gene. And where is BCR-ABL gene seen? Chronic myeloid leukemia. So one of the important uses of this imatinib and nilotinib is in treatment of chronic myeloid leukemia. More than 90% of the people have a dramatic remission when imatinib or nilotinib are used in chronic myeloid leukemia. And the best part of this is this tyrosine protein kinase, which is overexpressed in the malignant cells because of the abnormality in the BCR-ABL gene, will not be there in the normal cells. So that is the big advantage. The normal bone marrow cells, the neurons, the mucosal epithelium, the hair follicle, the gonads, they don't have this type of a tyrosine protein kinase. So these drugs are going to selectively block the abnormal tyrosine kinase, which is resulting from the BCR-ABL gene in chronic myeloid leukemia. So you will have full benefit from stopping the proliferation of the abnormal myeloid cells in chronic myeloid leukemia without causing any collateral injury to any normal tissue in our body. And that is the biggest advantage of this compound. That is why we call them as targeted chemotherapeutic agents for cancer. They are targeting specifically only that particular pathophysiological component which is responsible for the proliferation of the tumors and don't have effect on the other physiological systems in the body, and therefore they don't have significant adverse effects. So bone marrow depression, peripheral neuropathy, abdominal pain, diarrhea, gonadal suppression, hair follicle being damaged, and then loss of hair, all that is not there with these compounds. This is the biggest advantage of these compounds, and these can be given orally without causing much irritation to the gastrointestinal tract. Though anything that is given orally can cause some amount of nausea and epigastric distress, it's not really big time problem with imatinib or nilotinib. Are they so good that they don't have any adverse effect at all? There are some adverse effects. They can cause sodium and water retention. They can cause sodium and water retention related expansion of plasma volume, and they may precipitate congestive heart failure. So this is one important problem with these compounds. They cause sodium and water retention. They can cause expansion of the plasma volume. They can precipitate congestive heart failure. Of course, the nausea, vomiting, abdominal pain, diarrhea, to some extent you can write, but they are not really the dose limiting thing. The dose limiting thing is a plasma volume expansion due to sodium and water retention and also increased risk of congestive heart failure. Apart from that, these compounds are really very well tolerated, and more than 90% of the people that are given this in chronic myeloid leukemia show a remission without having any adverse effect on the bone marrow or any other tissue in our body. That is the brilliant part of these compounds. But over a period of time, what happens is the malignant cells become intelligent and they will change the structure of the tyrosine protein kinase, and it no longer will bind to imatinib. Then you can use nilotinib. So imatinib resistant malignant cells will still be able to respond to nilotinib. So that is the advantage of nilotinib. Nilotinib is also a tyrosine protein kinase inhibitor, but it can bind to the tyrosine protein kinase which is altered in structure and which is formed in response to imatinib exposure by the malignant cells. So if you have constantly exposed malignant cells to imatinib, the malignant cells will become intelligent and they will form a tyrosine protein kinase which doesn't recognize imatinib, but still nilotinib will be able to bind to it, and nilotinib will be able to inhibit the protein kinase, and it will be able to reduce the cell count in people with chronic myeloid leukemia. So is it only chronic myeloid leukemia tyrosine protein kinase that imatinib, nilotinib work, or are there other tumors also where tyrosine protein kinase is expressed in large quantities, and therefore even there they have a pharmacological role? They have pharmacological role in some other tumors also, but the primary thing from an undergraduate perspective, if imatinib, nilotinib is there, you have to remember chronic myeloid leukemia. Apart from this, if additionally you remember dermatofibrosarcoma protuberans, that is even better. Dermatofibrosarcoma protuberans is a malignancy where the fibroblasts actually become so uncontrolled in their ability to proliferate that they give rise to a life-threatening tumor. And there again the dysregulation happens because of another type of tyrosine protein kinase, and that tyrosine protein kinase is called platelet derived growth factor tyrosine kinase. So the platelet derived growth factor receptor is also a tyrosine kinase type of receptor, and platelet derived growth factor is implicated in dermatofibrosarcoma protuberans. So dermatofibrosarcoma protuberans is a malignancy. In that malignancy, the signaling protein is actually platelet derived growth factor. See, for example, like endometrial cancer, as estrogen is a stimulus. For prostate cancer, as testosterone is a stimulus. Similarly, what is the stimulus for dermatofibrosarcoma protuberans? For the dermatofibrosarcoma protuberans, the stimulus is actually a platelet derived growth factor. Now, platelet derived growth factor, what does it do? Platelet derived growth factor binds to receptors called platelet derived growth factor receptors. And how does the signal transduction happen? The signal transduction happens by protein kinases, and those protein kinases can be inhibited by both imatinib as well as nilotinib. So imatinib, nilotinib can also be used in treatment of advanced stages of dermatofibrosarcoma protuberans, which is due to stimulation by platelet derived growth factor, because the receptor, which is tyrosine protein kinase type of receptor, imatinib can inhibit even that receptor, and it can therefore be useful in that particular condition, that is dermatofibrosarcoma protuberans also. Another thing is There is another gene called the c-KIT gene, C-KIT KIT. c-KIT gene. The c-KIT gene is implicated in gastrointestinal tract stromal tumors. So this c-KIT gene, the abnormal product of the c-KIT gene is also a abnormal tyrosine protein kinase. And that tyrosine protein kinase, whenever it is overexpressed in the gastrointestinal tract stromal cells, that will lead to phosphorylation of so many intracellular proteins. Those proteins will again trigger the action of many anti-apoptotic proteins, and those anti-apoptotic proteins will lead to massive proliferation of the gastrointestinal tract stromal cells, leading to gastrointestinal tract stromal tumors. So you have to remember that tyrosine protein kinases are responsible for upregulating the cell proliferation rate in multiple tumors. One of them is chronic myeloid leukemia, the other one is in dermatofibrosarcoma protuberans, and the third one is in case of gastrointestinal stromal tumors. All of these three, there are protein kinases, and these protein kinases are upregulated, and if you can have a drug which can go and inhibit these protein kinases, you will get benefit in all three tumors, that is chronic myeloid leukemia, dermatofibrosarcoma protuberans, and the third one, that is gastrointestinal stromal tumors. So the gastrointestinal stromal tumors, the tyrosine kinase is determined by a gene abnormality. The gene is called c-KIT proto-oncogene. And of course BCR-ABL gene is responsible for the problem in chronic myeloid leukemia, and people with dermatofibrosarcoma protuberans, the problem is with a mutation in the platelet derived growth factor receptor. So platelet derived growth factor receptor is abnormal, and when the platelet derived growth factor binds to it, it responds exaggeratedly and leads to excessive cell proliferation. So for PG entrances, if you want to remember imatinib, nilotinib, you can remember that they are used in three conditions. One is gastrointestinal stromal tract tumors, next is chronic myeloid leukemia, and the third one is dermatofibrosarcoma protuberans. But if only one you have to remember chronic myeloid leukemia. And the difference between imatinib and nilotinib is nilotinib can work even in imatinib resistant malignant cells. And what are the adverse effects of these compounds? These compounds can cause sodium and water retention, they can cause plasma volume expansion, they may cause hypertension, they may cause congestive heart failure. So those are the adverse effects of this imatinib and nilotinib. Don't write bone marrow depression, don't write secondary infections, don't write secondary malignancies, don't write gonadal depression, infertility, sterility, don't write that, don't write alopecia, don't write significant nausea, vomiting. Those are not really most important adverse effects with this compound. It's only sodium and water retention, volume expansion, hypertension, congestive heart failure. And the uses, you should actually know it from the tip of your tongue, and one of them classically is chronic myeloid leukemia. Additionally, you can also say that tyrosine protein kinase inhibitors that are responsible for activation of the platelet derived growth factor related signal transduction, there also in dermatofibrosarcoma protuberans you use it. And the second one is you can also use in c-KIT proto-oncogene mediated tyrosine kinase receptors, that is gastrointestinal stromal tumors. So gastrointestinal stromal tumors, and then chronic myeloid leukemia and dermatofibrosarcoma protuberans, these are the important uses of imatinib and nilotinib. Now similarly, there are certain other receptors which are responsible for regulating the cell rates of proliferation, and that is EGF receptors, epidermal growth factor receptors. These epidermal growth factor receptors are useful for regulating the cell proliferation capability, especially in the pulmonary epithelium, and also head and neck cancers, and also in colorectal cancer. So epidermal growth factor receptors are upregulated in colorectal cancer, some of the head and neck cancers, and in lung cancers. Which type of lung cancer? Small cell or non-small cell? Non-small cell lung cancer. And in non-small cell also, which type of variant? Non-small cell also, that non-small cell which is seen in non-smokers and which is seen in females. So EGF receptor upregulation is responsible for lung cancer among females and non-smokers, and that type of epidermal growth factor receptor upregulation can be easily targeted with these compounds, geftinib, erlotinib and cetuximab. So geftinib and erlotinib can be given orally. Cetuximab is a monoclonal antibody, is given parenterally. All of them target the epidermal growth factor receptor. Now, what are the tumors that are associated with the epidermal growth factor receptor upregulation? You know straight away, one is lung cancer, non-small cell lung cancer, and that too in non-smokers and females. They respond very well. The other one is epidermal growth factor receptor upregulated tumor is head and neck cancers. And the other one is where the epidermal growth factor receptor is upregulated and still cancer can happen is colorectal cancer. So these compounds can be used. So what are the toxicities of these compounds? Geftinib is reasonably well tolerated orally given. Erlotinib reasonably orally given. Geftinib can cause hepatic dysfunction. Erlotinib can cause hepatic dysfunction. So both of them can cause hepatic dysfunction. So if you compare geftinib and erlotinib, erlotinib causes hepatic dysfunction little more than geftinib, and geftinib and erlotinib apart from this can also cause GI distress. And apart from hepatic dysfunction and GI distress, one important adverse effects of geftinib and erlotinib is very important adverse effect is interstitial pulmonary fibrosis. Interstitial pulmonary fibrosis is one of the important adverse effects of geftinib and erlotinib. So by inhibiting the epidermal growth factor receptor, they are actually producing the clinical benefit in non-small cell lung cancer, especially that cancer which is common in females and non-smokers. It is also useful in malignancies related to head and neck. It is also useful in malignancies like colorectal cancer. But one important adverse effect in the long term with both geftinib and erlotinib is that they can lead to hepatic dysfunction and also interstitial pulmonary fibrosis. So interstitial fibrosis, that is whatever thin strands of collagen are there in between the alveoli, they will become even more coarse and dense, and excessive fibrous tissue gets deposited in between the alveoli, and that will interfere with the diffusion function of the alveoli, and that will lead to respiratory failure. So that is called interstitial lung disease. Fibrosis is possible with geftinib and erlotinib. Then cetuximab, of course, is a monoclonal antibody, will do the same thing, inhibit the EGRF receptor, which is upregulated in these three cancers that I told you: head and neck cancer, colorectal cancer, and the lung cancer, non-small cell lung cancer, especially in females and non-smokers. But cetuximab is a chimeric antibody, that is the major portion is actually mouse derived and the minor portion in this antibody is human derived, and therefore there is a risk of allergy, hypersensitivity and anaphylaxis with this. Of course, it can also cause some amount of interstitial pulmonary disease risk. So cetuximab is used in colorectal cancer, advanced or metastatic. So this is about the targeted drugs, two broad categories: tyrosine protease kinase inhibitors and the EGF receptor inhibitors. Now we go to, because we know angiogenesis inhibitors, we know that malignancy cannot thrive unless there is blood supply. So many malignancies actually they first form the new blood vessels and then only the rate of proliferation increases. So angiogenesis is an important aspect of malignancies. Now we target angiogenesis by using angiogenesis inhibitors in treatment of malignancies such as bevacizumab and sunitinib. These are angiogenesis inhibitors. There is a small difference between the two. Bevacizumab is a direct inhibitor of vascular endothelium derived growth factor. So vascular endothelium derived growth factor is produced in large amounts by malignant cells. Why do malignant cells produce this compound in large amounts? Because they want more and more angiogenesis to happen, more and more blood vessel network to be formed, so that more and more nutrients are available to the malignant cells and the malignant cells can proliferate even more. So the malignant cells are intelligent. They actually start production of vascular endothelium derived growth factor, and they also promote the synthesis of VEGF from the vascular endothelium. So what do? We give bevacizumab. And what does bevacizumab do? Bevacizumab goes and binds to the vascular endothelium derived growth factor and doesn't allow the vascular endothelium derived growth factor to bind onto the blood vessels or the precursors of the blood vessels to trigger new blood vessel formation. So bevacizumab is a direct inhibitor of angiogenesis. It inhibits the vascular endothelium derived growth factor A, and by inhibiting the vascular endothelium derived growth factor A, it interferes with the neovascularization, and when neovascularization is not there, the cancer cells, which have a huge need for blood supply, they will die because of lack of oxygen and nutrition. So bevacizumab is used in treatment of metastatic colorectal carcinoma. One of the important uses of bevacizumab is metastatic colorectal carcinoma. Bevacizumab is now also increasingly used in proliferative diabetic nephropathy. So proliferative variant of diabetic retinopathy, where there is increased formation of the blood vessels on the surface of retina, and these blood vessels are so friable, so weak, and they are so overloaded with blood that in diabetic retinopathy, when those abnormal blood vessels they bleed, they lead to loss of vision. So retinal bleed will lead to loss of vision, and that is all because of new blood vessel formation. How to stop new blood vessel formation? Give bevacizumab. So bevacizumab intraocular injection is one of the important indications in treatment of diabetic retinopathy of proliferative nature. Apart from that, bevacizumab is used in treatment of colorectal cancer, advanced stage colorectal cancer, that is metastatic colorectal cancer. Then what are the side effects of bevacizumab? Bevacizumab can lead to hypertension, bevacizumab can lead to stroke, bevacizumab can lead to poor wound healing, because wound healing requires angiogenesis. Now if you use angiogenesis inhibitors because you don't want the malignant cells to proliferate, someone with an injury will also have a problem. Their injury will not heal, because for injury heal also to happen you need angiogenesis, and bevacizumab inhibits angiogenesis. So that is one other limitation. Bevacizumab can cause delayed wound healing or poor wound healing, and bevacizumab can cause hypertension. Bevacizumab can increase the risk of stroke because of hypertension, and this bevacizumab is also used in conditions like proliferative diabetic retinopathy, where you want to inhibit angiogenesis. If someone has peptic ulcer disease also, bevacizumab should be very carefully administered, because if peptic ulcer is there and if it is about to heal, it requires the angiogenesis to happen. If you give bevacizumab, the healing of the peptic ulcer may be dramatically affected and the person will come with a bleeding GI ulcer. So that we should be careful. Other than that, bevacizumab can also cause some amount of hepatic dysfunction. So it can cause hepatic dysfunction, it can cause poor wound healing, it can also cause epigastric distress and interfere with the healing of a peptic ulcer and can worsen the peptic ulcer, and it can cause hypertension and complications with hypertension like heart failure and stroke. So that is about bevacizumab, which is a inhibitor of the vascular endothelium derived growth factor A, and by inhibiting angiogenesis reduces the tumor burden. So in the angiogenesis inhibitors, another drug is there which is called sunitinib. Sunitinib and bevacizumab, the difference is bevacizumab, we all know, just now 2 minutes ago I have mentioned, bevacizumab binds to and inhibits the vascular endothelium growth factor directly, whereas sunitinib is an inhibitor of the vascular endothelium growth factor receptor. So it acts at the receptor level, whereas bevacizumab acts at the molecule itself. So bevacizumab blocks the vascular endothelium growth factor itself, whereas sunitinib doesn't really go and block the angiogenesis factors, vascular endothelium derived growth factor. It actually inhibits the signal transduction. It blocks the receptor to which the vascular endothelium growth factor binds. So vascular endothelium growth factor receptor inhibitor is sunitinib, vascular endothelium growth factor direct inhibitor is bevacizumab. So everything else for sunitinib remains the same. Sunitinib also has got the role in treatment of advanced and metastatic colorectal cancer, and sunitinib acts at a different level of angiogenesis inhibition, not by directly blocking the vascular endothelium derived growth factor, but by inhibiting the signal transduction after the vascular endothelium growth factor has bound to the receptor. So signal transduction is interfered, and another thing is sunitinib does not allow the vascular endothelium derived growth factor to bind to the receptor. So two mechanisms are there in sunitinib's action. Either it will not allow the vascular endothelium derived growth factor to occupy the receptor because the receptor is occupied by sunitinib, or sunitinib, once it occupies the receptors, can lead to the effects which will not allow the signal transduction of angiogenesis factors to be synthesized when vascular endothelium growth factor binds to the receptor. See, the simple way is, for example, there is a receptor, vascular endothelium growth factor wants to come and bind to that vascular endothelium growth factor receptor, sunitinib doesn't allow. Somehow if vascular endothelium growth factor still comes and binds to the receptor, sunitinib will not allow the signal transduction, so the receptor will not become activated. So the angiogenetic proteins that have to be formed in response to the vascular endothelium growth factor will not be formed in the presence of sunitinib. So that is about sunitinib, and sunitinib can be used in lung cancers also. So bevacizumab we know we use in colorectal cancer and diabetic retinopathy. Sunitinib can also be used apart from the colorectal cancer in lung cancer, and sunitinib can also be used in breast cancer. Sunitinib can also be used in glioblastoma, that is the central nervous system tumor, brain tumors. So breast tumors, brain tumors, colorectal carcinoma and renal cell carcinoma also sunitinib can be used. And what are the side effects? Similar to bevacizumab, poor wound healing will be there, peptic ulcer may perforate, peptic ulcer may become worse, and then hepatic dysfunction may be there, and hypertension will be there, heart failure could happen. So these are the effects. Apart from this, these drugs can cause proteinuria also. Both bevacizumab and sunitinib can cause proteinuria. Not only that, sunitinib is also found to cause hypothyroidism. This was once asked in a good entrance examination, a central institute I guess, where they said angiogenesis inhibitors can produce all of the following except. They said poor wound healing, that is true. They said aggravation of peptic ulcer, that is also true. They said hepatic dysfunction, that is also true. And then they said hypothyroidism, that is also true. They said nephropathy, proteinuria, that is also true. They said plasma volume expansion and heart failure, that is also true. So these are all the features of angiogenesis inhibitors as adverse effects. So there could be proteinuria, there could be heart failure, there could be volume expansion, there could be poor wound healing, there could be hepatic dysfunction, there could be peptic ulcer aggravation, and there could be proteinuria. Additionally, there could be hypothyroidism with sunitinib but not with bevacizumab. Then another important category that is there, and only one drug in that for undergraduates to be discussed, is bortezomib in the category of proteasome inhibitors. This is very exciting. Proteasome and what is its role and what type of tumor. Proteasome is active in one tumor called as multiple myeloma. Multiple myeloma is again a malignancy with very poor prognosis, and often it is missed early and people come late in the stage and very little can be done. So mortality rate is very high with the multiple myeloma. And in multiple myeloma, the drug that we use is a proteasome inhibitor called bortezomib. Bortezomib is a boron containing compound, that is why it is bortezomib. It's a boron containing compound. Then what does this bortezomib do? How does it help in reducing the excessive cell counts in malignancies, especially the tumors such as multiple myeloma? How does it work? Bortezomib's mechanism you can understand once you understand what is a proteasome and what does the proteasome do. So proteasome is of course one of the components of the cell, and it is expressed very highly in a malignant cell. And what is the normal function of a proteasome? Once we understand that, then we'll know what will happen when you inhibit the proteasome. So normally cell cycle is regulated by so many factors. The rate at which the cell proliferates is determined by so many factors, including so many intracellular signaling mechanisms. Now there is something called apoptosis and there is something called anti-apoptosis. Apoptosis will keep the cell number in check, and anti-apoptosis will lead to cell proliferation which is uncontrolled and excessive, and that may lead to malignant transformation of any particular tissue. So now you know that there is apoptosis facilitating proteins in our cell and there are anti-apoptotic proteins in our cell. Now look at the anti-apoptotic protein. So there is an anti-apoptotic protein which is not usually allowed to act, because our body knows if anti-apoptotic protein acts, malignancy will develop. So that anti-apoptotic protein in all our cells is inactive in the cytoplasm, and that is called NFK beta. That is NFK beta, nuclear factor for activation of transcription K beta, NFK beta. So this NFK beta, normally when it gets activated, it has the ability to synthesize anti-apoptotic proteins, and if anti-apoptotic proteins are high, then malignancy will develop. So the body knows that these proteins that are there in the cytoplasm, the NFK beta, it has to be kept in the cytoplasm only. It should not be allowed to go to the nucleus, because if it goes to the nucleus, it will cause transcription of certain portions of the DNA, and it will lead to formation of some proteins which may act as anti-apoptotic proteins and will lead to the risk of malignancies. So this NFK beta is maintained in the cytoplasm. Why does it always remain in cytoplasm in a normal individual? Why does it not go into the nucleus? Because someone is holding back in the nucleus, in the cytoplasm. Someone is not allowing it to go into the nucleus. Who is not allowing the NFK beta to go into the nucleus? Another inhibitory protein to which it is bound, and that inhibitory protein is called IK beta. So the IK beta is an inhibitory protein. That inhibitory protein is bound to the NFK beta, so that the NFK beta cannot go into the nucleus. But in people who have multiple myeloma, there is some abnormality in the cell, and then what happens is the IK beta is separated from the NFK beta. Now who is separating the IK beta from the NFK beta? That is the proteasome. So what happens in multiple myeloma is the proteasome is activated. It is exaggeratedly activated. And what is the function of proteasome? Proteasome's function is to free the NFK beta from the IK beta, and when the NFK beta is free from the IK beta, the NFK beta can go into the nucleus and it will cause specifically transcription of that portions of the DNA which will lead to formation of anti-apoptotic proteins, and anti-apoptotic proteins will lead to excessive cell proliferation. So why in multiple myeloma the excessive cell proliferation is there? Because in those cells the proteasome is excessively active. Because the proteasome is excessively active in the cell, whatever NFK beta is there, which is actually a cell cycle regulating protein which is not allowed to go into the nucleus unless and until it is absolutely necessary. Because of this abnormality in people with multiple myeloma, the proteasome becomes excessively active, will break down the bond between the NFK beta and the IK beta, and then the NFK beta goes into the nucleus, causes synthesis of proteins which are responsible for anti-apoptotic action and cell death. So what we do is we inhibit the proteasome. Proteasome which is excessively active is responsible for the multiple myeloma. So we inhibit the proteasome. So proteasome inhibitor is bortezomib, and one important indication for bortezomib's use is in multiple myeloma. And what are the adverse effects of bortezomib? Bortezomib has got two important adverse effects. One is peripheral neuropathy and the second one is bone marrow depression. So peripheral neuropathy, bone marrow depression, and the third one is diarrhea. So these three are important adverse effects of bortezomib. So I may repeat it another time because it will be easy for you. What happens with multiple myeloma is there is a component in the cell of those myeloma cells called as proteasome. And what is the function of this proteasome? The function of the proteasome is to break the bond between NFK beta and I beta. Normally NFK beta doesn't go into the nucleus unless it is absolutely essential, but when proteasome is high in quantity, it will break the bond between the NFK beta and the I beta, and then the NFK beta goes into the nucleus, and in the nucleus it will lead to transcription of that segments of the DNA which will form certain proteins, and those proteins are all anti-apoptotic in nature, and that will lead to excessive cell proliferation. All this started because of the proteasome breaking the bond between NFK beta and I beta. So what do we have to do? We have to inhibit the proteasome. How to inhibit proteasome? Give bortezomib. So bortezomib will do what we need. And what are the adverse effects of bortezomib when you use in multiple myeloma? The adverse effects are it can cause bone marrow depression, it can cause peripheral neuropathy, and it can cause diarrhea. So that is about bortezomib. Then there are certain monoclonal antibodies that are used in cancer. These are also targeted therapies. So for example, in the breast cancer, you must have come across in pathology that there are certain cell surface receptors that regulate rate of cell proliferation. For example, the HER2 receptor, HER2-NEU, Herceptin it is called. The HER receptors which are there on the surface of these breast cancer cells, they are responsible for upregulating the ability of the cell to proliferate. Now what we do is we use some monoclonal antibody called trastuzumab. Trastuzumab is a humanized monoclonal antibody, so the risk of adverse reactions will be very low, and this monoclonal antibody trastuzumab has the ability to go and bind to the HER2 receptor on the breast cancer cell, and once it binds, it does not allow the signal transduction to happen through the HER2 new receptor. So the HER2 receptor, whenever it is inhibited by trastuzumab, the malignant rate of proliferation of the tumor comes down dramatically, and that will reduce the tumor burden, and that is how the cell cycle arrest happens. Then there is another thing called rituximab. Rituximab is a chimeric monoclonal antibody. That is, the major fraction of this is from the mouse and the minor portion is from the human. Rituximab is a CD20 monoclonal antibody. That is, it is an antibody which is formed against the CD20. We know that most non-Hodgkin's lymphomas, they have a CD20 antigen on the surface of the malignant cells, and that is the cell signaling pathway for the proliferation of these non-Hodgkin's lymphoma cells. If you block the CD20 receptor by using rituximab, that will help in controlling the rate of proliferation of the cells in non-Hodgkin's lymphoma. So anti-CD20 monoclonal antibody is rituximab, whereas monoclonal antibody against HER2 breast cancer cell receptor is trastuzumab. So rituximab used in non-Hodgkin's lymphoma, trastuzumab used in breast cancer. Then there are certain hormonal drugs that are used in cancer. Glucocorticoids, for example, you know, glucocorticoids are used in lymphomas because glucocorticoids have lymphocytotoxic action. Estrogens are used in prostate cancer, because estrogens, when they are given to the male, the estrogens will stimulate the anterior pituitary, and the anterior pituitary will then be suppressed. Normally what happens is, whether it is estrogen or testosterone, once there is a feedback inhibition, the anti-pituitary will not work. So it is a feedback inhibition. But you can't use androgens for feedback inhibition of anti-pituitary in a male with prostate cancer, because if you use androgens to cause feedback inhibition of the pituitary in the male, that will itself cause flare-up. Because androgen, even before it can go and act on the pituitary, it will act on the prostate and will flare up the prostate cancer. So you want to use a feedback inhibition type of a chemical for suppressing the pituitary. So you can use estrogens in the men. So that estrogen in men who have a prostate cancer, when you use this estrogen, causes feedback inhibition of the anterior pituitary and hypothalamus, and there will be suppression of the gonadal function, and that is how it can be used. Not only that, estrogens directly also reduce the density of the testosterone receptors. So that is one of the effects of estrogen. So whenever estrogens are given to a male, and if the prostate has lot of testosterone receptors expressed on its surface, estrogen will downregulate and also decrease the sensitivity of the testosterone receptors. So two reasons why estrogens are used in men with prostate cancer is, estrogens can cause feedback inhibition of the hypothalamic pituitary gonadal axis, therefore testosterone production will be low and the stimulus for the growth of prostate cancer is low. Another thing is, estrogen can directly acting on the prostate reduce the number of testosterone receptors and also sensitivity of the testosterone receptors to testosterone in prostatic cancer. Then you know, tamoxifen is used in breast cancer. It is a selective estrogen receptor modulator because it is a agonist in the endometrium, but it is an antagonist in the breast. That is why we call it selective estrogen receptor modulator. And tamoxifen can be used in both premenopausal as well as postmenopausal women. Estrogen receptor positive or estrogen receptor negative both respond to tamoxifen. And tamoxifen can be used for both prophylaxis as well as treatment of cancer, breast cancer. So if a first degree relative of a woman with breast cancer is there, if the first degree relative has not had cancer, but the prophylaxis of cancer can be contemplated by giving tamoxifen. So tamoxifen is an anti-cancer drug for breast cancer. If you have to remember, you can remember that it is used in both premenopausal women and postmenopausal women. It is useful for both prophylaxis as well as treatment. It can work both for estrogen receptor positive as well as estrogen receptor negative cancer. How does it work in estrogen receptor negative cancers? Because tamoxifen's mechanism is not only by blocking the estrogen receptors, it has an independent anti-malignancy action also by downregulating certain cyclin-dependent kinases which are responsible for cell proliferation. So tamoxifen is not only useful in estrogen receptor positive cancers, it is also useful in estrogen receptor negative cancers also. That is estrogen receptor negative breast cancers. Then aromatase inhibitors, we know letrozole. Letrozole is used only in postmenopausal women with breast cancer, and in premenopausal women it has no role. So letrozole can be used in treatment of advanced stages of breast cancer, especially in the postmenopausal women. And then in case of prostate cancers, where androgen is the driving force for the tumor to grow, is the stimulus to grow, then androgen how to block? By using anti-androgens like flutamide and bicalutamide. So in the topic on anti-androgens, you might have come across these two anti-androgens, flutamide and bicalutamide. Flutamide and bicalutamide are anti-androgen. They block the androgen receptors. So therefore they are useful in treating prostate cancer, which is primarily dependent on stimulus by androgen. So these are the hormonal drugs. Now quickly I will try to mention about some combination regimes. At least couple of combination regimes you should be knowing, which are used in treatment of cancers. One is called BEP, bleomycin, etoposide and cisplatin. Bleomycin, etoposide and cisplatin. So this bleomycin, etoposide and cisplatin combination is used in testicular cancers. I told you that you need always multiple drugs to treat a cancer, because you will prevent resistance, you will have much more cell killing power, and also the adverse effects will be low. The other thing is, there is a regime called as FOL-FOX, FOLFOX, FOL-FOX. So FOLFOX is 5-fluorouracil, leucovorin and oxaliplatin. So 5-fluorouracil and leucovorin and oxaliplatin. This is used in colorectal cancer. FOLFOX is used in colorectal cancer. There is another thing called FOL-FORI. FOL-FORI. FOL-FORI regime is again used in colorectal cancer and also sometimes head and neck cancers. So FOL-FORI regime is 5-fluorouracil, leucovorin. Leucovorin is again that formal tetrahydrofolate, and irinotecan. So FOL, FIRI, that is 5-fluorouracil, leucovorin, that is formal tetrahydrofolate. So FOL is for the folate, and then IR, that is irinotecan. So FOL, FOX, FOL, FIRI, they are used in colorectal cancers and head and neck cancers, whereas the BEP, that is bleomycin, etoposide, and cisplatin or oxaliplatin, is used in treatment of testicular tumors. There are other things like CHOP-R, CHOP-R. CHOP-R, C is cyclophosphamide, H is hydroxydonorubicin. CHOP-R. C is cyclophosphamide, H is hydroxydonorubicin. Hydroxydonorubicin is nothing but doxorubicin. So doxorubicin. And O is oncovin. Oncovin is other name of vincristine. Vincristine is also called as oncovin. ONCO, oncovin, vin. And P is prednisolone. Prednisolone is a corticosteroid, and right here you can see glucocorticoids, corticosteroids can be used in treatment of lymphomas. And then R. R is rituximab. I told you rituximab is a CD20 receptor blocker. The CD20 is expressed on the leukemia lymphoma cells, especially the lymphoma cells, and therefore in non-Hodgkin's lymphoma we use CHOP-R. CHOP-R. That means you use these drugs as a combination therapy. C stands for cyclophosphamide, H stands for hydroxydonorubicin, O stands for oncovin, which is vincristine, P stands for prednisolone, R stands for rituximab. As I told you, rituximab is a monoclonal antibody, CD20 receptor blocker, CD20 expressed on non-Hodgkin's lymphoma cells. So these are the regimes, and quickly now in the next 5 minutes I will tell you what are all the drugs that are available to ameliorate the adverse effects of anti-malignancy drugs. For example, if someone gets cisplatin therapy, and we know cisplatin is nephrotoxic, neurotoxic, and if you want to reduce the nephrotoxicity, neurotoxicity of cisplatin, can we give some compound? Yes, there is some compound called amifostine. 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 Amifostine is actually a thiophosphate. Thio means SH containing phosphate. It is a prodrug, and it is converted to active form in the body by action of the enzyme alkaline phosphatase. So in some AIMS entrance or PG entrance, somewhere PGI or in some international examination, they may ask, mention a drug which is used for ameliorating the toxicity of cisplatin. The answer is amifostine, and amifostine is a thiophosphate, and this amifostine is converted to active form by action of the enzyme alkaline phosphatase. It is given IV, and what are the adverse effects of this compound is it can cause hypotension. That is one important side effect of amifostine. Why it is used? To reduce the nephrotoxicity and neurotoxicity. What happens is cisplatin generates a lot of free oxide radicals, and those free oxide radicals can be neutralized by the SH bond that is there in the amifostine. Because amifostine, if you see technically, chemically, what is it? It is a thiophosphate. Thio means SH. So SH will be generating the hydrogen ions which will neutralize the free oxide radicals that are formed due to the metabolism of cisplatin, and that is how the nephrotoxicity, neurotoxicity comes down with amifostine. Then someone will ask you, if 5-fluoromethotrexate is given, if methotrexate can cause bone marrow depression, how to reverse it? Leucovorin, that is N5-formal tetrahydrofolate, within 3 hours. I have told you previously 15 milligrams to 50 milligrams can be given within 3 hours. The maximum is you can try up to 72 hours. After 72 hours, if you give, there is no use. So methotrexate, if bone marrow depression is happening, you want to recover the effect of the bone marrow. How to recover it? By giving within first 3 hours of giving methotrexate a compound called as leucovorin, which is nothing but N5-formal tetrahydrofolate. Then someone will ask you, if cyclophosphamide is given and there is hemorrhagic cystitis, if you want to treat that, what do you do? Then you say you give something called mercaptoethane sulfonate, MESNA. So MESNA is combined with cyclophosphamide to prevent the hemorrhagic cystitis potential of the metabolite of cyclophosphamide called acrolein. Acrolein is a metabolite of cyclophosphamide. It is an irritant to the bladder. That irritancy to the bladder you can reduce by coating the acrolein with a bond that is formed by MESNA with it. So how do you prevent the hemorrhagic cystitis with cyclophosphamide? Give MESNA. MESNA will go and bind to acrolein, and acrolein will not be able to cause the irritation of the bladder epithelium, will not cause hemorrhagic cystitis. Now someone asks, sir, all these drugs majority of the time cytotoxic, whatever you told, they cause bone marrow depression. How to recover the bone marrow depression if it is not due to methotrexate? Some other drugs also have it. For methotrexate anyway you have the leucovorin. For others, what do we have? The others, the important thing is you can give something called colony stimulating factors. And in that colony stimulating factors, especially because most importantly life threatening will be leukocyte count going down, especially the granulocyte count going down. So if the granulocyte goes down significantly, the person will become vulnerable to infection, the person will die due to septicemia. So if bone marrow depression, leukocyte count goes down, if granulocytes are low, can we give a granulocyte colony stimulating factor? Very much indeed. And the granulocyte colony stimulating factor is called filgrastim. Filgrastim, filgrastim. This is a very, very important 2-mark question. Mention some colony stimulating factors that are used to improve the leukocyte count after the bone marrow depression by using anti-malignancy drug, that is filgrastim. And so nearly 24 hours after the anti-malignancy chemotherapy is given, filgrastim is given at the dose of 5 microgram per kg body weight. Typically 300 microgram is given. It can be given subcutaneously, and then it will try to stimulate the bone marrow to form the leukocytes, the granulocytes, so the person will not be having excessive risk of leukopenia that can lead to septicemia and death. So that is filgrastim. There is something called granulocyte macrophage colony stimulating factor, and the GMCSF it is called, that is called molgramostim and sargramostim. Molgramostim, MOL mol, gramostim, GRAMOSTIM, molgramostim, and sargramostim, CASARGRAM, sargram OSTIM, sargramostim. So molgramostim, sargramostim, these are granulocyte macrophage colony stimulating factors. So they will not only increase the granulocytes, they will also increase the monocyte count. So monocytes gradually become macrophages. So granulocyte macrophage colony stimulating factor is molgramostim, MOLGRAMOSTIM. So both are used in bone marrow depression that happens secondary to anti-malignancy drug usage. Then someone will ask, sir, you told that anthracycline antibiotics except mitoxantrone, the daunorubicin, doxorubicin, epirubicin, they were having the ability to cause cardiotoxicity. So can we prevent the cardiotoxicity? Yes. What is the compound that is used for that cardiotoxicity? That compound is called dexrazoxane. DEXRAZOXANE, dexrazoxane. So dexrazoxane is a iron chelator, and most of the times, the free oxide radical generation requires iron. In pathology you study this Haber-Weiss reaction, Fenton's reaction. Free oxide radical generation, whenever cell injury happens, they require iron for the catalyst purpose, and therefore if you can remove the iron, then the free oxide radical formation will be significantly reduced and cardiotoxicity will be less. So anthracycline antibiotics, they actually cause free oxide radical formation, and the free oxide radical formation is accelerated in the presence of cellular iron, and that iron you can try to remove from the tissue by using iron chelator like dexrazoxane. So someone can ask, can you tell me some iron chelator which is used in malignancy? So you can always tell that dexrazoxane is an agent. It can reduce the cardiotoxic potential of anthracycline antibiotics. So these are all the things that I wanted to tell you. How can you rescue the bone marrow? If methotrexate bone marrow depression is there, give N5-formyl tetrahydrofolate. If bone marrow depression due to any other cytotoxic compounds is there and the leukocyte count has to be improved, you can give granulocyte colony stimulating factor like filgrastim. If you want to increase even the monocyte count, you can give molgramostim because it is a stimulator of both the granulocytes and the macrophage lineage. Then if someone has got cisplatin and developed and is at risk of developing nephrotoxicity or neurotoxicity, you want to reverse it, then you can use the compounds such as amifostine. Amifostine will remove the free oxide radicals and reduce the nephrotoxicity and neurotoxicity. And these are the things. If cyclophosphamide related injury to the bladder mucosa you want to reduce, you can use the compound like Mesna. So these are important methods by which you reduce the toxicity. And of course finally cardiotoxicity with anthracycline antibiotics can be reduced by pre-medication with a compound called dexrazoxane, which is an iron chelating agent. But other thing is, dexrazoxane, iron chelating agent, will to some extent reduce not only the side effect of doxorubicin, daunorubicin, it will to some extent reduce their cell count lowering capability also, because all anthracycline antibiotics, their mechanism of action to some extent is through free oxide radical generation, and free oxide radical generation requires iron. So their efficacy will also somehow come down, though the toxicity also comes down. So that is the caution between use of dexrazoxane and anti-malignancy drugs like anthracycline antibiotics. So I hope all of this is now known to you. Quickly, if you go through lots of compounds, cytotoxic, targeted, hormonal, In the alkylating agents, all of these compounds we studied, how do they work? Because these are all electrophilic compounds. They target the N7 of the guanine residue, which is rich in electrons, and they collapse the structure of the DNA. And then these are not cell cycle specific. They act in any phase of the cell cycle. So slowly replicating, fastly replicating, all cells will suffer the injury due to alkylating agents, and these can actually increase the risk of secondary malignancies. All the side effects like gonadal suppression, bone marrow depression, hair fall, and anemia, leukopenia, thrombocytopenia, diarrhea, all of them are there with this alkylating agent. They are not cell cycle specific. So even these alkylating agents like nitrosourea, striazines, that is dacarbazine, methylhydrazine, these are all very non-specific. They act on both normal cells as well as the proliferating cells. The important thing about nitrosourea is they act in the central nervous system. Carmustine, lomustine, they are used in treatment of central nervous system tumors. Dacarbazine, of course, in malignant melanoma. Temozolomide, again in brain tumors. Procarbazine, just now if you see CHOP, in that procarbazine can be used in non-Hodgkin's lymphoma, Hodgkin's lymphoma, and also procarbazine can be used in treatment of melanomas also. Then cisplatin, carboplatin, oxaliplatin, you can use all these three in basically ovarian and testicular cancers. Of course, they can be used, cisplatin especially can be used in cervical cancer also. And you know, cisplatin and oxaliplatin will have more of neuritis and nephrotoxicity, whereas carboplatin will have more of bone marrow depression. Then all these antimetabolites, you know, which inhibit dihydrofolate reductase enzyme methotrexate, and pemetrexate little different than methotrexate because pemetrexate directly inhibits thymidylate synthase more. Methotrexate also inhibits thymidylate synthase, but methotrexate inhibits primarily dihydrofolate reductase, less amount of thymidylate synthase. Pemetrexate primarily inhibits thymidylate synthase, to some extent dihydrofolate reductase. Then purine antagonists like mercaptopurine, thioguanine, azathioprine, and then the pyrimidine antagonist 5-fluorouracil, capecitabine, cytarabine. Capecitabine, cytarabine can be given orally, 5-fluorouracil parenterally. Then vinca alkaloids we discussed in the morning, how they prevent the polymerization of the microtubules and interrupt the M phase of the cell cycle, spindle formation is interrupted, and how they can be used in treatment of breast cancers and ovarian cancers and head and neck cancers, gastroesophageal cancers. And also vincristine we saw is useful in Win's tumor, in Ewing sarcoma, and in also neuroblastoma. And taxanes, paclitaxel, docetaxel, they are having a mechanism little different. They cause increased polymerization of the tubulin protein, and they don't allow the depolymerization. Therefore, they trap the proteins that is responsible for spindle formation without being available and interrupt the mitosis. These are cell cycle specific. They act in the M phase of the cell cycle. They are cell cycle specific, M phase. Then topoisomerase inhibitor, these are also relatively cell cycle specific. If you recollect in the morning I told you G2 phase specific, these ones. And then these are anti-malignancy antibiotics. They are not really very specific, but some people do put them in G1 phase, some people put in G1S and G2 also. So not really very non-specific, but to some extent they are between G1 and G2 you can put these anti-malignancy antibiotics. And then hydroxyurea, S phase of the cell cycle. Because hydroxyurea inhibits ribonucleotide reductase, that is, it doesn't allow the ribonucleotide to form deoxyribonucleotide, and that is needed for the S phase of the cell cycle, synthetic phase of the cell cycle, the DNA formation. So hydroxyurea acts on the S phase of the cell cycle. Aspergillase again, not really very specific. Then targeted drugs we know, imatinib, nilotinib. The important things is chronic myeloid leukemia, then also gastrointestinal stromal tumor, and also dermatofibrosarcoma protuberans. And geftinib, erlotinib, cetuximab, if you remember lung cancer, it is important. And what type of lung cancer? Which has EGF receptor upregulation. Which type of upregulation? In people with non-smokers and females. That is where it is more useful. Of course, they can be used in head and neck cancers also, especially the cetuximab. Then angiogenesis inhibitor, directly vascular endothelium derived growth factor blocker is bevacizumab, receptor blocker is sunitinib. Hypothyroidism is additional feature of sunitinib, which is not there with bevacizumab, but they interfere with wound healing. Both of them interfere with peptic ulcer healing. They can cause hypertension, and additionally, importantly, they can cause proteinuria and congestive heart failure. Now, bortezomib important because proteasome inhibitor. Proteasome actually is a trigger for multiple myeloma by actually synthesizing proteins that are anti-apoptotic in nature. So if you inhibit the proteasome, anti-apoptotic protein will not be formed. If anti-apoptotic protein is not formed, then the cell count comes down. One important problem with this is it is having a peripheral neuropathy and bone marrow depression and diarrhea as a side effect. Then trastuzumab for breast cancer, HER2 receptor blocker, rituximab CD2 receptor blocker, the CD20 receptor blocker, in case of non-Hodgkin's lymphoma. Then of course these you know, glucocorticoids for lymphomas, estrogens for prostate cancer, tamoxifen for breast cancer, then aromatase inhibitor letrozole for breast cancer, tamoxifen for both prophylaxis and treatment for positive as well as negative estrogen receptor, and premenopausal as well as postmenopausal women. Then anti-androgen flutamide in prostate cancer. So I think that completes comprehensively the entire topic of malignancies. So hopefully next class when I come this Friday, the 2 classes, I will complete the immunomodulators, that is immunosuppressants and immunostimulants, and that will be the end of the entire syllabus in pharmacology. So I will come back on Friday both in the morning and afternoon and take the immunomodulators topic.